Hello, dear students. After a long time, I am again going to discuss you the answers as well as the explanations of the multiple choice questions of autonomic nervous system. And the first question is, which of the following drug is most appropriate in the treatment of myasthenia gravis? And the options are neostigmine, succinylcholine, dantrolene and physostigmine. Now, myasthenia gravis is an autoimmune disorder in which the antibodies are formed again in the NM receptor, and if we can increases the acetylcholine at the muscle end plate by cholinesterase inhibitor, and that is neostigmine. Okay, so now the question arises in your mind that why not physostigmine? It is also a cholinesterase inhibitor, but it is having central as well as peripheral action, and that's why the preferred is neostigmine. Succinylcholine is a skeletal muscle relaxant. Same way dantrolene is also a skeletal muscle relaxant. So answer is neostigmine A. Atropine is contraindicated in. Atropine is an anticholinergic agent and it is preferred in the treatment of organophosphorus poisoning, which is most common in the farmers in our setup. It is also used in the mushroom poisoning because the cholinergic systems, it is activated in the mushroom poisoning. Okay. Symptomatic bradycardia and angle closure glaucoma, yes. Now the atropine causes significant rise in the intraocular tension, and you all know that in the angle closure glaucoma it is an emergency condition in which there is a tremendous rise in the intraocular pressure. So in this condition we can't afford even a slight rise in the intraocular pressure, and that's why atropine is absolutely contraindicated in angle closure glaucoma. Okay, drug of choice in anaphylactic shock. The options are dopamine, dobutamine, adrenaline and noradrenaline. You all know that in the anaphylactic shock, again it is an emergency condition in which there is a significant, because of the vasodilatation, there is a hypotension, laryngeal edema, and here we require a physiological antagonist of the histamine, and that is adrenaline. Adrenaline is the only life-saving drug in the condition of anaphylactic shock. Okay. Contraindication for the use of the beta blockers is, so you have to find out the contraindication. Bronchial asthma, prophylaxis of migraine, glaucoma and hypertension. Now the beta blockers, there are certain non-selective beta blockers, there are certain cardioselective beta blockers. Some are the cardiac use, some are the non-cardiac use. In the cardiac use, obviously you know that hypertension, angina, CCF and many more conditions. Non-cardiac use, propranolol is used for the prophylaxis of migraine. In the glaucoma, also the propranolol, timolol is used. But bronchial asthma, because beta blockers, it means that the beta 1 and beta 2 blockage. Now the beta 2 stimulation, it will lead to bronchodilation. So the beta blockage, it will lead to the bronchoconstriction. And that's why they are contraindicated in bronchial asthma. Okay, now you may feel that it's a very long case scenario, but you just make a habit to break down a question in the various compartment. A patient known case of myasthenia gravis was taking tablet neostigmine 50 mg 3 times a day since past 3 years. So a case of the myasthenia gravis, taking the treatment also, and patient is stable also. Now patient had developed infection. And obviously in any of such condition, there is chances of exacerbation of the condition. And for that the physician has doubled the dose of neostigmine. Okay. So on the next day, the patient consulted the physician with the complaints of severe muscular weakness, drooping of eyelid. You can see in the figure drooping of eyelid. Okay. Now this can be due to either the worsening of the myasthenia gravis. So it is known as the myasthenic crisis. Here I have written myasthenic gravis, but it is not myasthenia gravis, it is myasthenic crisis and cholinergic crisis. What is cholinergic crisis? That if you have increased the dose of the neostigmine, so if there is excessive cholinergic overactivity, it may lead to the condition which is similar to that of the myasthenic crisis. So how you can differentiate these two, because the clinical features are same. Okay, but the treatment is exactly opposite. In myasthenic crisis, you have to give the agent which increases the acetylcholine level, while in cholinergic crisis you have to stop the agent which increases the acetylcholine level. So option A, reduction in the dose of the neostigmine? No. Replace the neostigmine with pyridostigmine? It is also not going to be helpful because pyridostigmine is a longer acting agent than neostigmine. Then immediate hydroponium and then immediate intravenous administration of atropine. Atropine is also not going to help in this condition. Now hydroponium. Hydroponium is an ultra short acting agent. Now if you give, you just think that if you give the hydroponium in this condition, now if the patient is having myasthenic crisis, so the hydroponium, it significantly raises the level of the acetylcholine at the muscle end plate, but it is a very immediate release and it is for very short duration. So if the myasthenic crisis is there, there is immediate improvement. But if the cholinergic crisis is there is a slight worsening of the condition, but it is having a very short duration of the action. So again, within a few seconds or at the most minutes, the original condition will come. And that's why in this condition we have to select the agent which rapidly increases the level of the acetylcholine at the motor end plate, but for a very short duration. So if the patient is having myasthenic crisis, the condition improves, and if the cholinergic crisis, the condition worsens, but for a very short duration. And that's why the answer is C. Now a 34 years old female consulted the dentist for severe toothache and increased sensitivity. Now dentist decided the root canal treatment. Okay. Now obviously this procedure is done under the local anesthesia, lignocaine, and additionally the adrenaline has been added. Now adrenaline is used to prolong the duration of local anesthetic agent. Now the question is, this action is mediated through which receptor? Now adrenaline acts on alpha 1, alpha 2, beta 1 and beta 2 receptors. So the option C automatically goes out. Now this how this adrenaline prolongs the duration of the local anesthesia? By causing peripheral vasoconstriction, and because of this the lignocaine remains in the local area for a long period of the time, and that's why there is a prolongation in the duration of local anesthetic action, and this action is mediated through alpha 1 stimulation. So the answer is D, alpha 1. Now identify the drug acting at the site X. Here you can see now terminal where the acetylcholine is released, act on the nicotinic and muscarinic receptor. Okay, now here you have to focus on the drug X. Now what the drug X is doing, it inhibits the uptake of acetylcholine in the presynaptic vesicle. So you have to find the agent which inhibits the uptake of acetylcholine in presynaptic vesicle, and that is vasamicol. Okay. Which of the following agent is to be instilled into the eye for checking the refractory error in 18 years old male? Now here you have to check the refractory error, and that's why here there is a requirement of both mydriasis and cycloplasia. Now this is achieved with the help of the anticholinergic agent, and the options are, there are 3 anticholinergic agent and D phenylephrine. It is a sympathomimetic agent. It is used only when there is a requirement of mydriasis and no cycloplasia. So option D goes out. Now out of the A, B and C, you require an agent which is having a very rapid onset and short duration, so quickest and briefest action, and that is achieved with tropicamide. Now which of the following drug is commonly used in narcoanalysis? One of the anticholinergic drug is used, and here you are confused between atropine and scopolamine, but the scopolamine, it is having a central CNS depression, slightly euphoriant action also, and it is most commonly used in the narcoanalysis. So the answer is B, scopolamine. Preferred anticholinergic agent for the management of detrusor instability. Now here we have to select. Now you all know that the M3 receptors which are present into the bladder, okay, and in case of the detrusor instability, you require an agent which relaxes the bladder smooth muscle, and that's why the capacity of the bladder increases. So, but in addition to the anticholinergic agent, we require a vasoselective anticholinergic agent, and all of these, ometropine, dicyclomine, flavoxate and glycopyrrolate, all these are anticholinergic agents, but out of these, the flavoxate, it is a vasoselective anticholinergic agent. So the answer is flavoxate. Other agents are tolterodine. Okay. Now, which dose range of dopamine is preferred in the treatment of cardiogenic shock with the purpose to increase the urinary output? Now, dopamine is the preferred drug in the cardiogenic shock, and dopamine is having a dose dependent action. It means that on the different dosage it produces the different action. And in the cardiogenic shock, we require an increased urinary output, and so that's the load on the heart reduces, and this is achieved when the dopamine acts selectively on the renal and mesenteric blood vessels, and that is achieved in a dose range of 2 to 5 microgram per kg per minute. Okay, so the answer is A. If you further increase the dose, the dopamine will act on beta 1 receptor. If you further increase in the dose more than 20 microgram per kg per minute, it acts on the alpha 1 receptor, which is not desired. So one has, in the treatment of the congestive cardiac failure, one has to use the dose of dopamine somewhere in between the 2 to 15 microgram per kg per minute. Which of the following beta receptor blocker is having additional alpha receptor blocking activity as well as the free radical scavenging property? Now here you have to remember the classification. I told you there are the first generation, second generation and the third generation. First generation, the non-selective beta blockers, second generation cardioselective, and third generation which are having additional alpha blocking activity, and some of the agents are having free radical scavenging or antioxidant property also. And these agents are labetalol and carvedilol, but out of these two, carvedilol, it is having additional alpha blocking as well as free radical scavenging or antioxidant properties. So the answer is C. A 13-year-old girl has been prescribed salbutamol through the metered dose inhaler at the time of the onset of acute bronchial asthma. We all know that in the bronchial asthma there is a need of bronchodilator agent. Okay, and here the bronchodilator is salbutamol. Now this bronchodilatory activity of the salbutamol is due to activation of beta 1, activation of beta 2, blockage of beta 1 or blockage of beta 2. Here you have to find out that, so the bronchodilation, so on the bronchi, on the bronchial smooth muscles, which beta receptors are present. Now the receptors that are present are beta 2. Fine. Now the next question is whether the activation leads to the bronchodilation or blockage. Obviously the activation will lead to the bronchodilation. So the answer is B. Acetylcholine is not used in clinical practice because it is very toxic and costly. No. It produces highly selective action. No. It produces a wide variety of action that we don't want. It is not available commercially. No. It is instantly hydrolyzed. Yes. Acetylcholine, when you give, even if you give intravenously, even if you give intravenous bolus, it is immediately hydrolyzed by the estrus present in the plasma. So that's why it is not used in clinical practice. Now, which of the following agent is to be preferred to provide the immediate symptomatic relief in a case of benign hypertrophy of prostate? Now, in benign prostatic hypertrophy, we require immediate relief if we can relaxes the sphincter, prostatic capsule, prostatic smooth muscle, and this is possible only if you give a alpha blocker. Okay. Now, so here there are two alpha blockers, prazosin and yohimbine, but we require a alpha 1 blocker, and that's why the answer is prazosin. Even though the finasteride, which is 5 alpha reductase inhibitor, it can be useful, but it will reduces the prostatic size, and so the improvement we'll see after 3 to 4 weeks. And that's why for the immediate relief, symptomatic relief, the prazosin or the selective alpha 1 blocker is preferred. Which of the following agent is a reversible non-selective alpha blocker? Again, the alpha blockers, They are divided into one is the irreversible, that is phenoxybenzamine, and then reversible. Again in reversible they are divided into non-selective and selective. Prazosin and tamsulosin, these are selective alpha 1 blocker, while the phentolamine is a non-selective but reversible. Okay, while the phenoxybenzamine, it is a non-selective as well as irreversible. So the answer is phentolamine. Pardon some of the mistakes in the PowerPoint presentation because I have made it very hurriedly. Drug of the choice for the immediate reduction of the intraocular pressure in case of acute congestive glaucoma is, now acute congestive glaucoma is an emergency condition and in which there is a immediate reduction in the intraocular pressure is required, even though latanoprost, dipivaprin, pilocarpine, they are effective. But IV mannitol, it very quickly reduces the intraocular pressure in minutes, and that's why it is the drug of choice. Okay. Following are the non-cardiac uses of beta blockers, except, as I have told you, the beta blockers are used in the non-cardiac as well as cardiac condition. In the non-cardiac, propranolol is used for the prophylaxis of migraine. Propranolol is also used for the treatment of the open angle glaucoma. For the essential tremor, they are also helpful, but for the restless leg syndrome, beta blockers are not useful. Mechanism of action of pralidoxime in organophosphorus poisoning. Pralidoxime, it is used in the treatment of organophosphorus poisoning after atropine, and its function is to reactivate the enzyme. Okay, it is not used to inhibit the acetylcholine activity. It has nothing to do. So the stimulation of acetylcholine receptor, no. Inhibition of the breakdown, no. Blockage of the receptor, no. But yes, reactivation of the acetylcholine esterase enzyme. And so the answer is D.